So today's topic is on tennis elbow and tennis and elbow injuries in general, although we can't cover them all, of course, but there'll be a fair selection. The elbow pain can cover really a whole range of things. Tendinopathies are clearly the most common, I guess, that present lateral epicondylosis rather than epicondylitis, and I'll talk about that in a minute. And really, tennis elbow is a very common condition, so-called golfer's elbow. Medial epicondylitis, the radial tunnel syndrome, which I mentioned at the end as well, which is really compression of the radial nerve just distal to the elbow. Funny condition to diagnose, quite uncommon, but certainly quite a cause of disability. The various arthritis, there's various types, osteoarthritis and rheumatoid, and then tears, and certainly triceps tendon tears are quite uncommon, but certainly biceps or degenerative biceps tears we see not uncommonly and can be quite a source of problems. Electron spurs, electron bursitis, as well as things like ulnar nerve compression and trauma. And the classic about elbow pathology, such as mentioned here, is often it's quite easy to diagnose, or generally is, but it's often quite hard to treat, which is very frustrating. Now, where do you start? I think history examination is clearly always the first start. The elbow structures are generally quite superficial and fairly easy to palpate, to feel. We can find specific tenderness, be it lateral epicondylitis, be it, I'll just let a few in. And lateral epicondylitis, and so it's very easy to examine. Range of motion is very easy to check and test, and it's critically important in terms of losing subtle range of motion and similar. And also swelling and deformity is quite a good trigger about what's actually going on. The first investigation clearly is X-ray, and I think this is really the message on a lot of the talks we've been giving over these last month or so, is that X-rays and good history examination is really the primary way to approach these problems, and will generally give you the answer. I find ultrasound, which is becoming quite a common, often initial investigation, is somewhat confusing and predictable, and it's usually quite unhelpful in terms of often confusing the nature of the pathology. So, and often is it variance to the primary diagnosis or preliminary diagnosis. I'll use CT fairly regularly for things like arthritis, but certainly MRI if I'm concerned about the diagnosis. As I was saying before, just butt in if you've got any particular questions that you wish to raise as we go along. So really the take-home message that I'd like to perhaps start with and perhaps finish with eventually is that not all pain is tennis elbow, although clearly this is very commonly and covers most of them. Questions? The elbow is really very accessible. It's mechanically fairly simple in general terms and is easy to examine. There are some specific provocative tests, wrist extension testing, prone lifting testing, various stress and strains. History is often very illustrative and the examination is usually diagnostic. What's interesting about 90% of tennis elbow or lateral epicondylosis will get better without surgery, and the treatment in a lot of these areas is still quite controversial. The message I'd also like to give is that I think steroid injections can provide some early benefit, but they're actually worse long term, and I'll show some papers to cover this. And so again, I reiterate, injections are generally bad. Now, and exercises in particular, eccentric exercise, eccentric loading is beneficial, and I'll talk about that shortly. So again, if you Google, using Dr. Google tennis elbow, you'll find you'll get 117 million hits. So it's extremely common out there in social media, and certainly in the Twitter sphere and the Google sphere. This is quite an interesting little paper which came out maybe a couple of years ago, 3 years ago, from actually a Brisbane group, looking at the incidence of tennis elbow in the Australian sort of GP practice or GP world, and looking at a 15-year observational study on how things are progressing. And what they find is that tennis elbow is actually very common in the general population or general practice population, and at a rate similar to hip and knee arthritis, so about 3% of the population. GP diagnosis is essentially a clinical one, and without usually recourse to diagnostic tests or imaging. The management usually consists of advice and education, some GP procedural type techniques, often stretching and strengthening exercises, often referral to a physiotherapist, And generally, these management protocols largely follow what's in the literature and what's recommended. However, that of course is the exception of steroid injections, which over the last 15 years of this review series in this peer-reviewed open journal, found that steroid injections are still commonly used, despite the fact there's virtually no evidence to support their efficacy or use. So that's maybe a time for a bit of consensus on guidelines. So what is lateral epicondylosis or lateral tennis elbow? Well, it's obviously lateral arm pain, it's pain on wrist extension, and the prone lift test, where you actually lift a chair with the wrist in that pronated position, is really quite helpful in pinpointing the pain. There's often pain and tenderness over the lateral epicondyle, and this is, I think, is diagnostic. If it's not tender over the lateral epicondyle and specifically there, sometimes elsewhere, but specifically there, it's probably not tennis elbow and maybe something else. Grip strength is usually reduced. Activities of daily living are often reduced, and it usually develops either suddenly with some specific lifting incident or over time, and often relates to repetitive injuries, so repetitive motions such as, you know, gripping a racket or tennis, from which it obviously came, but it's clearly not all tennis elbow. What I think is interesting is it's not actually an itis. So the idea of using anti-inflammatories, steroids, NSAIDs and things are maybe not all that logical in terms of treating the underlying pathology, because it's more a failure of healing rather than necessarily a failure of some sort of inflammatory disease. And it's usually a small micro tear with failure to heal. And I think therein lies the treatment options, which, as I said, don't generally include steroid. So the treatments are icing and that sort of thing. Still, elbow straps are quite important, and I'll mention again in a minute. Anti-inflammatories for mainly for the analgesic effect, but perhaps not much else. The physiotherapy is quite helpful for strengthening and stretching muscles. Injections I'll mention again, and also surgery in a very small group of patients who maybe don't improve over a period of 6 months and are really having trouble. And the aim is to actually remove the damaged section of tendon and then try and repair the remaining tendon. It's not really a repair technique; it's really a process of removing damaged tissues and moving on from there. So, what is the evidence? Where should we start to look at? Because obviously, evidence-based medicine should be what should be driving us. Well, I think this is quite an interesting study that I saw some years ago. In fact, I was actually I reviewed this article for the journal, the British Journal, Medical Journal, and it's actually from an Australian group. And their aim was to look at the treatment outcomes for exercise, steroids, or wait and see approach in a randomised trial. Peter Brooks is quite a prominent national researcher. So the objective was to investigate the efficacy over a year period, a single-blind randomised trial from Brisbane. They had a good number of participants, 198 participants, age up to 65, with a diagnosis of tennis elbow, which had been there for at least 6 weeks and had not received any treatment. And this is really the piece de resistance, or the actual data, which will stick on for a little while. But down the left-hand side are the various rating scales from severity rating, and they rated this out of 100. How bad is your elbow? How much trouble does it give you? The second is pain-free. What was the grip strength compared to the other side? So pain-free grip, percentage of normal, and success. And so patients were asked to rate the success of the treatment to date based on their subjective outcome from the sort of 3-month period onwards, so 3, 6, 12, 24. So if we go to the top page again, top graph, we can see wait and see steroid injections with the white and blue, and then the physiotherapy with the I guess ochre and mauve and aqua. What we see, and we often do see this, is a steroid injection causes an early and quite definite improvement in symptoms, but in fact finishes up worse. So early gain and longer pain. So steroid injections are shown to have good early response, but finish up much worse, and so really should be avoided. The wait and see again, and the steroid and the cortisone and the physio rather are associated with nice steady improvement overall, with a bit of physio and stretching probably providing the best outcome. So I think this does fit with what is really the current push, that wait and see will do quite well, and the natural history is generally pretty positive, but a bit of intervention with some physio and strengthening makes a lot of sense. But steroids do not. Again, grip strength similarly follows that pattern of regaining pretty much 100% grip strength within a year for all, apart from that group who had a cortisone injection. And again, success overall, again, 90% do quite well, which fits with the published literature if you wait and see or try some therapy. And the therapy, as you can see on that bottom graph, provides some early gains, and then it sort of flattens out. So I think the message in this paper is pretty clear, that physiotherapy combined with some elbow manipulation and exercises has a superior benefit to wait and see in the first 6 weeks, and steroid injections really provide major long-term problems, as you can, as we mentioned. They do well early, but then there's a high recurrence rate and a deficit long-term. So this is one paper. Well, what this paper actually shows is that we can see that the cortisone injection is useful early, but later recurrence. Physiotherapy is quite useful at giving an early start, but again, and provides a better, more predictable long-term outcome. And again, one of the useful things of physio, not to be too demeaning, is that physio basically stops people having other things done. Shockwave therapy, PRP, injections. The therapy exercise program really keeps people ticking along quietly and avoiding them doing things they probably shouldn't be doing. Is this just one paper? Well, no. Well, this is another paper again. This is actually an American Journal of Medical Associate, and actually I think it's also from an Australian group. Among patients with chronic unilateral lateral epicondylalgia, the use of steroid injections versus placebo injection produced a worse outcome at a year, so consistent with the previous study, but they found that physio did not result in any much difference. I think it depends on the right physio though. Again, another study. This is a paper again from an Australian group, looking at a whole range of interventions, and they're really comparing corticosteroid injections with no intervention physio, steroid with physio, anti-inflammatory physio, placebo injection, and also platelet-rich plasma. And to explain the diagram, basically the dotted line down the middle, directly below the words short, medium, and long term, is the sort of the no response outcome. So when the dots are to the left, it favors not the steroid. When it's to the right, it favors the steroid. And so you can see that early on, all the studies show some benefit from the steroid injection, which fits with the other papers. Intermediate, this is around the 6-month mark, looking worse, and long term worse. And pretty much everything that steroid does compared to physio, anti-inflammatories, placebo, or PRP, steroids do worse. So I think the message is getting quite clear that cortisone injections are not a good idea. And so I think we go back to this paper here, which basically says that the advice on management is actually pretty sound, apart from the use of steroids, which doesn't support the use in this condition. Well, what can we use? Well, what about platelet-rich plasma or autologous blood, which is now becoming a bit of a rage, particularly in one or two physio practices in town, radiology practices in town. And this is quite a nice randomized controlled trial from, I think, Sweden. And what they found when they compared platelet-rich plasma, where you spin down a fraction of blood and then re-inject it, straight autologous blood, and then in steroid injections, they found really there was no difference. They had a good number of patients, 20 or 40 in each group, at 1, 2, 3, 5, and 12-month reviews. No crossovers, good follow-up. No difference in pain, DASH scores, which is an upper limb score, at any time point. So really, it didn't improve the function at a year. And so, for the sake of doing something, this doesn't help at all. Probably does make them worse, but it's expensive and doesn't help. So they recommend against the use in patients with epicondylitis, unless there's a further evidence to the date. Now, PRP people would suggest that different combinations are used, different formulations are used, and so therefore not all PRP or platelet-rich plasma injections are the same. But clearly, there have been no studies to date to show that it makes a big difference. And this one joins that group. Needling, a lot of therapists like needling and versus steroid injection. Again, not much difference long term. And I guess the problem is that they're comparing dry needling against a very poor comparator. So it's at least perhaps a bit better than the worst than one of the bad treatments. So I don't think this provides much strong support either. And they also noted the steroid injections had some skin atrophy and some whitening as well. So there is actually morbidity from the cortisone. What about shock therapy? There's another radiology group in town very keen on using shock therapy, this extracorporeal shock therapy under ultrasound control. This is a meta-analysis. So they looked at 12 studies over nearly 1,000 patients, and they're looking at whether it makes much difference in grip strength and pain and the duration of symptoms. Again, did not show clinically important improvement in pain reduction or grip strength over the period of the study, which was out to a year. So again, this doesn't seem to be providing much benefit either. I mean, if it can be shown that it works in bigger groups in different formulations or different patients, maybe it'll help. Sometimes the late presentation patients were a little bit better than the early ones, but clearly as a routine treatment, it doesn't cut the mustard. Counterforce braces, these are quite a useful and fairly safe process. It tries to reduce the load through the lateral epicondyle, this is really a wrist injury where the wrist extensor muscles are pulling on the lateral epicondyle. And so these counterforce braces, as you can see here, there's a whole range of them. In fact, you find 1.7 million references to them on the internet. And they try and reduce the load through the elbow. This is quite a good way to at least control symptoms, not much, and while the condition generally gets better on its own. Counterforce, again here we can see here, wrist braces are quite helpful also, as this is really a wrist injury where the wrist extensor muscles are pulling on the lateral epicondyle. This will actually allow the load to be reduced while the patients can get back to their normal activities in a more graduated fashion. Well, what does work? Well, we know that there's some increasing interest in things like eccentric training and stretching exercises for other conditions such as tendo Achilles and also patella tendinopathy. And this is a controlled trial on the knee which showed some benefits in terms of stretching and eccentric use. What about the elbow? This is probably one of the best. This is a paper that reviewed a whole range of resistance exercises and sort of exercise process for tennis elbow or lateral epicondylosis. March 2012. Basically, there were lots of studies. They found 11 studies with nearly 600 patients in these studies, which were either randomized or non-randomized, a whole sort of bevy of combinations of studies. But in this systematic review, basically all the studies reported that resistance exercises improved pain and grip strength. Eccentric exercises were most studies, and it seems a combination of stretching and eccentric exercises improve things. I guess this paper here, how was in contrast to that, which they found there was no improvement with eccentric exercises, but these diagrams which they showed in the paper itself, I guess, are indicative of the sort of difficulty in providing a realistic and I guess convenient way of applying these exercises. Now, you can see here that the patient needs to manually resist the movement on their arm. They've got to get it right. There's a lot of instruction here. It's really quite a tedious and quite long and quite demanding program. So I think one of the problems here is if you can't deliver the load in a way that the patient can do it, then you're probably going to find the patient's not going to be able to comply with the treatment. So I'm not sure this necessarily is a good reflection on what's going to be done. Certainly for years we've been using a towel twist. You get a towel and just twisting an exercise with a towel, which I'll talk about in a minute. But this is a sort of an attempt to try and emulate this sort of study or this sort of process here, and often it's been a bit variable. So what is eccentric exercise? And I'm sure there's a few physios online now which will understand what it is quite clearly. But eccentric exercises really are the muscles contracting as the wrist is lengthening. So as the wrist comes down and resists going down under a load, as you can see on the diagram, this is eccentric exercise, eccentric contraction. So when the wrist comes up, concentric. When it comes down, that's eccentric. And so things like push-ups, when you're doing a push-up, that's concentric up. And then...
Hi, Liz, how are you?
Say again? So I think that now what eccentric exercises tend to do, though, they're actually stronger than concentric, and eccentric exercises seem to be more effective at building muscle and stimulating a muscle response. And so a combination of concentric and eccentric exercises may be the answer to stimulating the lateral epicondyle to sort of get over its injury and start to heal. So, and this is quite a good way of actually providing that better concentric eccentric combination. Probably one of the best studies that's been around the place for a while is this paper from the US in the Journal of Shoulder and Elbow Surgery in 2010, which looked at the use of a elastic recoil or a rubber bar twisting exercises in 20 patients. Again, it was randomized rather, and they compared this to a standard physiotherapy stretching group. What they found was that in this group, there was a definite improvement or markedly improved with the addition of an eccentric wrist extensor exercise program rather than simple stretching and strengthening. And you see on the diagram on the left here, this patient, so-called patient, is showing how this is actually from the TheraBand therapy company. The questions? Put their hand if they want to ask a question, or we can butt in any time you like. Anyway, so this is showing this twisting exercise program. There are obviously many ways of doing this, but what was interesting is that the improvement in all variables was actually with the eccentric group. So the DASH, which is an upper limb score, the visual analog scale for pain, the tenderness and strength, all improved quite substantially as a result of the use of this elastic recoil bar to improve the load. Is this been validated in other studies? Well, yes, this is another study from clinical rehabilitation, again, a Swedish study looking at 120 patients in an eccentric versus concentric graded exercise program. Again, they found that eccentric graded exercise reduces pain and improves muscle strength in this chronic tennis elbow group more effectively than simple stretching or concentric. So simple strengthening wasn't enough. It was applying this eccentric load as well, which provided that stimulus to get the tissue to heal, or the damaged area to heal. Again, another study, effectiveness of eccentric strengthening in the treatment of lateral epicondylitis. I think this is a Chinese study, I think. Anyway, what they found, again, if you just go straight to the bottom, this was a meta-analysis looking at a whole series of studies. I think they found eight articles covering the comparison of eccentric versus simple strengthening and other modalities. The treatment program with eccentric strengthening of adequate intensity and duration was most effective in treating tendinopathy. So I think the message is starting to come through that there's a very specific program. At the clinic here, I've been using this device, which is basically a silicon bar, which basically the patients can twist as you can do. I've got a small disclaimer in that I used to use a towel for twisting exercises. It became quite frustrated. It didn't seem to be providing a sufficient load. So about nearly 10 years ago, I spoke to this company, Locker Room, and they've now made this device, which is the tennis elbow twister, which is available. I get nothing out of it, received or expected, but it's just handy that I use for my patients. So I basically give all my tennis elbow patients this particular bar, which allows us to apply a concentric and eccentric load. It's convenient and seems to provide the sort of stimulus, and certainly based on the previous paper by Tyler, it seems to be of some help. Now, we've been doing some research to try and validate whether this is truly a reasonable process. And so if you look on the left-hand side here, this is a patient who's obviously been hooked up with this. You can see the arrow. You can see the arrows there. Some of them. Anyway, what base the patient's got? We're just looking at the EMG response, so the muscle response to the patient as they do the exercise. So ready. So yeah, I'll just run through this again. So patient holds the device. The left arm is obviously the affected arm. So what the patient will do is they'll extend the wrist. So that's concentric loading. And they hold it and then rest forward, come forward, and that's now an eccentric load. So what we see here, if we look at the diagram here, that's the concentric loading here as the always stimulates. And then when it comes forward, that's the eccentric sort of wind down as the wrist sort of winds down. So it's an alternating concentric eccentric load, and you can increase the amount of loading by simply flexing the right wrist as well to increase the load through the left arm. And depending where you hold the bar, whether out on the ends or close to the middle, will change the tension. So I've certainly found this quite a useful way to give patients to conveniently apply this eccentric loading program. So the summary in total is basically education advice. It'll get better, 90% get better. Wait and see is not unreasonable. Well, that's pretty frustrating. Analgesics, either oral or even some local Voltaren or something, just to give them something to do. Straps and splints are quite helpful. Eccentric loading exercises seem to be the key for applying a treatment modality, and physiotherapy as needed. Can obviously supervise this because many patients won't understand how to do this sort of exercise program. I think the message is also getting clear that steroids, PRP, autologous blood, interferential or witchcraft don't seem to be providing the sort of solutions to tennis elbow, that the quick fix that we need. And the real challenge, of course, is to how to explain that the quick fix you will get from steroids, in fact, provides a long-term deficit. And overall, about 90% get better anyway between 3 and 6 months, although this is out to a year. When they're not getting better, and I won't do on this too much, but and probably 6 months is often as long as people can stand, depending on their progress. If they're still getting better, they'll hang it out. But if it's really reached a bit of a crisis at 6 months, it's not something that needs to be done. And we do know that not 8 should be 80%, not 8. That's a bit rough. 80 to 90% are effective for surgery, and basically involves cutting away the damaged tissue, as you can see in this diagram, and then simply drilling the lateral epicondyle to try and stimulate ingrowth, and then get a healing response. There are lots of treatment options. There's open technique, just a straightforward incision to take it all down. There's a percutaneous with a needle. There's also arthroscopic debridement of the deep surface of the extensor carpi radialis brevis muscle, which seems to be the muscle that seems to be identifies the major culprit that fails. And again, this is a study not so long, a couple of years ago, which compared open versus arthroscopic versus percutaneous release over a nearly 10-year period. This is again a meta-analysis looking at multiple studies, nearly 1,500 patients with good numbers. Again, more patients were pain-free with the open approach than the arthroscopic. Not much difference, but certainly the open was certainly quite efficacious, and it's a small procedures. And their comment was that open debridement as a technique was more effective than to achieve a pain-free outcome. Yeah, there was another study more recently which compared arthroscopic debridement, which is becoming quite popular now, compared to open debridement with the management. Again, it's another systematic review. I mean, individual studies are useful, but these bigger meta-analyses are probably more useful to get an idea or indicative of what's happening. Again, no major difference between arthroscopic or open, but certainly arthroscopic was longer, had higher risks, may have created some other issues. And if you look at the diagram at the bottom, basically this is the so-called forest plot, with the central line indicating sort of neutral benefits either or. It's all sort of heading towards the open approach being perhaps of some benefit. It was certainly shorter, took less time, and seemed to provide the outcomes. And so again, no major improvements in the arthroscopic approach, unless there's this idea that maybe there's something intra-articular like a radial head fracture or something else, not actually tennis elbow. I'll mention very briefly. I might stop there for a second. Any questions from anybody who wants to raise any issues?
Michael, given that you said it's not really an inflammatory process, if you're giving them oral analgesics, do you just try and stick to paracetamol, or do you find that they do get better benefit, at least anecdotally, out of something like ibuprofen or Voltaren?
Well, I'll be taking a task, but I think the anti-inflammatories have two functions. Firstly, they have a true anti-inflammatory process. They affect prostaglandin levels, and certainly in things like rheumatoid arthritis, where there's a true inflammatory program. Then I think knocking off those prostaglandins is quite important. But if you look at the biomechanics or whatever it is, the chemistry, it takes about 2 or 3 weeks to achieve that. And really, the idea of actually taking ibuprofen and having immediate relief does not fit with the pharmacokinetics at all. However, I think that the anti-inflammatories are actually very effective with a Panadol-like function. I think they clearly have a Panadol-like effect as well.
Yeah.
And taking them once a day, the dosing formula is better. I think the availability is better. You take one, and I think it's more convenient. But of course, it comes with a stick in terms of complications. So I sort of explain to patients that it's not an inflammatory process. They're not taking these tablets for their anti-inflammatory role. They're taking it to provide a sort of Panadol-like, more convenient dosing type regime, and it comes at a risk. So they're better off taking a Panadol Osteo, I think, than the anti-inflammatories. Now, some people swear by the anti-inflammatories, and so so be it. I don't think the effect is that bad, but really, it doesn't make a lot of sense. And also, it comes with some side effects. So it's sort of easy to suggest not to do it. If they really have to, but if they really have to, then go for it. And I think what one of the papers sort of basically cynically said, that as long as you do something that's not dangerous, it'll stop them doing something that is. So it's a matter of sort of keeping the patient amused while the problem gets better.
Right.
And so then we think like Voltaren gel and stuff laterally. I mean, it feels better. Maybe it might stimulate some local effect, and maybe the Voltaren has a Panadol-like effect systemically anyway. So it probably doesn't do a lot of harm. And I think you're better off than sticking it full of steroid.
Yep.
Does that make sense? Any other questions at all? Who's at a tennis elbow? Does anyone not have one? Because certainly of the group here, would probably be a third would. Anyway, okay. So radial tunnel syndrome. I haven't got much of this, but basically, as the radial nerve comes down, can you see my arrow? As it comes down, as the radial nerve comes down past the elbow, in front of the elbow, it passes underneath the supinator muscle, which is about where that little ring is. And often there can be small vessels, small bits of fascia, which can compress the posterior interosseous nerve and cause pain radiating down the arm. And there's a bit of an overlap between lateral epicondylitis and condylosis and the radial tunnel syndrome. And often some authors suggest they should both be released together if the patient has failed conservative treatments. But radial tunnel syndrome is one of those diagnoses of exclusion. It's tenderness on the proximal forearm rather than actually in the lateral epicondyle. It can give finger extension weakness and can be quite disabling in the arm, but it's uncommon. I see probably just a few of these. They're often quite clear when the condition is well established, and they're really quite effectively released if need be. But it's not tennis elbow, but often there's a bit of overlap between them. The other thing is bicep tendonitis. But I saw one of these patients yesterday who was referred as a tennis elbow, but in fact, if you examine the patient, they're actually quite tender right in the front of the elbow, where you can see the diagram shows the distal biceps insertion. She was a cleaner. She'd had progressively increasing pain over about 3 or 4 months, and if you test or just palpate the biceps tendon as it runs down the front of the elbow onto the radial tuberosity, it becomes quite painful. And so you finish up with this very tender area anteriorly, which is a bicep tendinosis. Now, the treatment is really rest. The difficulty, of course, is that it's very tempting to put a bit of steroid in there, and this may be an inflammatory process in response to a chronic degenerative tear. The difficulty, of course, is if you start sticking steroid in degenerative tears, you can cause the rupture to actually extend. And so things like Achilles tendonitis are very badly managed by injection. So I think the problem with biceps tendinosis or tendonitis is it's best treated by simply resting and avoiding aggravation. Again, simple analgesics, maybe some stretching exercises. If it gets to a real crisis, maybe a bit of steroid, but generally these need to be assessed under an MRI to see how much tear there is, and if it's more than 50%, they probably need debriding and repairing, which sounds a little surgically aggressive, but that's maybe the best option. Classically, tenderness in the biceps tendon, down the front of the elbow, pain on rotation, pain particularly on supination and rotation right by the elbow here, and generally very successfully managed. If they've got a big tear, they drag on for 3 to 6 months, quite frustrating, but repairing them if they're partially torn or cracked is a good option. So I think I'll probably leave it there. There's a whole lot of other things to talk about as well. Triceps tendinosis, small tears, but I think we'll perhaps leave that for any questions. It's a bit, tennis elbow is a bit much in the morning. I mean, talking about tennis elbow is a bit like a poison chalice. You really don't want to see them too many because they're just so hard to treat. But having this little tennis elbow device really does give patients something to do. And I think actually there's pretty good evidence that it actually stimulates the appropriate response by the body to resolve the problem. So there you go. Any questions at all? I don't have a lot of problem cases because really they're a bit they're not that exciting and there's not much to see. But certainly a patient presenting with a month history of lateral elbow pain and wrist extension, pain lifting, aching, can't play sport, can't play tennis particular. Again, analgesics, stretching exercises, and really the elastic recall eccentric exercises are probably the mainstay that I'd be looking at for the patients. Any comments?
I think education is probably the key, getting out that steroids are not the answer, because that's generally what the patient wants when they turn up.
Yeah, I think that diagram fed off. I have that diagram printed out a couple of times, and I've shown patients what the solution is, and they can, because obviously if you say not to use steroid, not to use these magical solutions, they get very upset that you're not doing something to try and help them out. But
yeah,
if you can sort of show them that in fact it's not going to provide a really good safe solution, then they can be a little more circumspect about what things they might want to do.
I'm going to print it out too.
Well, it's pretty clear, isn't it? I mean, it
yeah,
does. And I think we certainly see things like in shoulder as well, where subacromial steroid injections have been shown to provide definitely some improvements in a fair substantial majority or fair substantial number of patients. But in fact, the long-term results are poor, and any sort of comparative studies really look quite bad. I mean, I think one of your colleagues had a go at me about criticising subacromial steroid injections, and in fact. The argument was that in fact we only see patients who actually don't do well, and so we finish up having a very distorted view of what actually, how good these things are. But in fact, my comments on steroid injections either in the shoulder or the elbow or wherever are not based on my experience purely, but based on pretty good randomised trials, which are now pretty evident.
Yeah, sure.
I think for tendonitis in the fingers, for de Quervain's, they work brilliantly, and the evidence will support that. But certainly in the shoulder or the elbow, and certainly in the tendon of Achilles, not a good option. And the real worry is the biceps. It probably promotes the next stage, which might be a surgical repair. But still, if that's where it's going, maybe bringing it on is not such a bad thing.
Yeah.
If your surgeon is okay. Questions?
Michael, can I just also ask, not necessarily relevant to the tennis elbow, but if you are x-raying the elbow, are there particular views that you like to see? I was interested last week that there were 4 knee views that Richard Clarnett was keen to have if we were referring patients through to him, and I didn't do all 4 of them previously. So I'm just wondering what views, if that you particularly want to look at on an elbow x-ray if we're sending people through.
Well, I think it depends on your examination and what you find. I mean, patients that Richard's seeing have got arthritis. Have they got joint line narrowing?
Yeah. And
if that joint line narrowing is going to be shown by standing X-rays, then clearly that's what they need to do. If is their patella tracking correctly? Again, the skyline view will show that. As far as the elbow goes, if you've got a radial head fracture, for example, you've got tendons over the radial head, so in that sort of region between the tennis elbow tendinous on the picture there and the radial tunnel tendinous, then a radial head view is quite helpful. It's sort of like an oblique view of the elbow. Also, if you've got a patient with some early arthritic changes, they've got ulnar nerve symptoms, and you think they might have a small osteophyte impacting into the sort of ulnar tunnel here, then there's an ulnar tunnel view as well. But generally, AP and lateral is pretty much all you need for an elbow, maybe a radial head as well. So I think usually you can pick up most of them on both of those. You can see effusions, you can see posterior osteophytes, you can see often radial head fractures, you can see changes of the lateral epicondyle, which will indicate sort of chronic lateral epicondylosis. You can see fractures most times. But again, you're guided by your examination, and I think that I would generally use just the 3 AP lateral and radial head, with maybe the sort of ulnar tunnel view if I was concerned that there might be some sort of impingement of an osteophyte into the ulnar tunnel.
Yeah. Okay. Thank you.
Again, I think most patients now come on with ultrasounds as well, which always shows a tear, and the patient then says, "Well, are you going to repair it?" I said, "Well, actually, this isn't. The treatment is actually to cut it out, not to repair it." So it does take some confusion. And of course, the problem there, of course, is that the ultrasound then leads on to an offer to fix their problem with an injection, which often rapidly follows on. I'm not sure whether those in the crew who are watching on use steroid injections very much. But it certainly hasn't. It's not supported, apparently. I mean, I guess you might do it in desperation if the patient is getting completely beside themselves. And I think certainly surgery becomes a bit of a desperation type thing.
Yeah, we try and keep it that way.
Yeah, fair enough.
Michael, was Chris. Oh, sorry, one of the physios.
Yep.
Just wanted to reiterate the point of the you made about doing some physio to bide the time. Really, I actually think that's true, and I think our role really has a big role in reinforcing that education that someone like yourself might have started. And this is the course of the natural course of what's going to happen, and these are things that are okay to do. These are things that might help you. So along with the strength and eccentric, concentric stuff, it's not the sort of thing that we would need to see often, and if I see them, I might see them a couple of times within a couple of weeks, and then maybe a month, and just say this is what we expect it to run. So I think that's a fair comment that physio, if we can reinforce and stop the other type of the things that they seek out, then that's a good thing long term.
Yeah, and he's not trying to push this tennis elbow twister, but patients really do quite like it. I think it gives them something to more specifically use and do. And I think with the evidence that I've just presented, and this is now becoming pretty common. I mean, when I developed or tried to look for this device back in about 2008, actually, I started looking at it. I tried to get doorknobs that actually rotated, and that was pretty expensive, a bit silly. I then got some springs and made some handles to try and use springs, because the towel exercises didn't seem to be providing any sort of resistance or recoil at all. And then this fellow in this Lockerwood, locker room sports in Brisbane, makes a whole lot of similar type of devices, and they made these silicon recoil bar, which in fact has now become available about the same time as a TheraBand type bar, or Flex bar, I think it's called. They're about $30, $40 each. Pretty sensitive. The price is pretty price sensitive, I think. But basically, I find you give them something to go away with. It's like having a drug script or something from a GP in a way. They go over something in their hand, they can now start to work on, rather than advice. Wait and see doesn't really cut the mustard, really, because there's 117 million hits on Google on tennis elbow.
Yeah.
So really, there's a lot of work out there saying what will and won't work, and mostly what will with it, but not proven. But I find this just becomes a very useful, do this, here's your exercise program, take it away, and that seems to be, and as long as someone shows them how to do it properly, then, and I think, I showed some diagrams of our EMG work, and I think we can actually show that it does actually simulate and does actually recruit the muscles in the way that we sort of had envisioned it and had planned it. So I think it seems to work. Anyway.
Can't go wrong getting a bit strong. That's right.
Oh, very funny. Yeah, good on you.
Yeah, good.
Okay.
The other thing we see in general practice is with kids with pulled elbow, and very simply treated. But what are the long-term effects of treatment versus non-treatment there? Do you know?
Of pulled elbow? I don't think much. Again, I've seen probably about 10 in my career, frankly. I think the pulled elbow problem relates usually to the father who lifted the kid up too aggressively. And so the major pathology is to the father, because mum's not very impressed that they've injured the kid's elbow. So I think that the pulled elbow, as I understand it, is really a small imbrication of a small bit of synovial rim. I think if you leave it alone, it goes away. I haven't done kids enough to see them enough recently, but I think the whole thing resolves eventually. But if you can do the little reduction manoeuvre, it seems to resolve the thing rapidly. So I don't think I've ever seen any pulled elbow that I haven't actually managed to. Does everyone know what they're talking about? Obviously you do. Have you seen ones that haven't been treated, or is that your concern?
Yeah, I just wondering whether, when you treat them, what you're doing is reducing the superior radial subluxation. And
well, again, you may have spoken to some of my pediatric colleagues more recently this, but my impression was that you got, because of the distraction and then compression, typically the kid gets picked up by their hands, the radial head, I guess, gets distracted, a little bit of synovial rim gets caught and gets jammed, and then they're stuck, and it stays stuck until you do something to flick it out of the road. So I don't think it's a true subluxation. I think it's really a sort of, it's a more distraction and imbrication of a bit of soft tissue, which then gets jammed. And so the I think that I remember quite clearly you come into the room, it's a very classic sort of sign. The kid's miserable and crying, mum's holding the kid, everyone's upset, dad's looking pretty sheepish because he picked the kid up and lifted the elbow, and there's some major injury because it's obviously quite sore. You walk up to the patient, you grab the arm, you give it a real flick, the kid cries, mum thinks you've killed the kid, dad's about to kill you, you leave the room rapidly, you come back about a minute later and everyone's happy. So
that's right.
But I think to call it a subluxation or some sort of instability pattern, I think actually sort of overcome. That's my recall, because I haven't seen this for probably a fair while.
Yeah. Okay. Thanks.
Any other questions, right? If not, we may even wrap it up unless there's something further. This will be online. This talk for those who want, as well as the other talks on arthritis, tendinosis, knees, and also hips. I think next week is on ACL and sporting injuries from Will Duncan. So the numbers are growing. I think my first talk has something like 30 or 40 revisits. So I think quite clearly this time of the day may not suit everybody. The talks are there, so hopefully there's some use, and we would certainly appreciate any feedback as to whether this is a useful or we should stop getting up so early and sleep in and have a cup of coffee earlier. So unless there are any further comments or questions, I can run for 15 minutes if need be, but I think we might wrap it up. Anybody else wishes to answer the questions? If not, I will sign off and say, invite you to listen to Will Duncan next week when he talks about how to manage knees. See you all.
Thanks
very much, Michael.
Cheers.
Thanks for joining us. Okay.
Bye.
Thanks a lot.
Bye.
Thank you. Bye-bye.